Good day, everyone, and welcome to this amazing panel on the topic of mental health crisis. I'm Natasha Müller. I will be your moderator for today. And for way of background, I'm an impact investor, a philanthropist, and a mental health activist. I've been funding the mental health space for about 15 years. I'm also the founder of Kokoro, one of the partners or co-collaborators on this series event. And it's a not-for-profit that aims to mobilize human and financial capital behind global mental health. Before we get started, I just wanted to make a note about the topic. Mental health crisis is a phrase that can mean many different things in many different contexts. But there is so much to explore and we could go all over the place. But for the sake of this conversation, we're going to focus on the issue of suicide and suicide prevention. And to help ground the conversation, I wanted to share some statistics to give a sense of the scale of the issue that we face that affects every region around the world. So according to the WHO, who we have here today, every 40 seconds, someone dies by suicide and 20 more try. And that's a statistic that in the 15 years that I've been in this space has not changed. According to UNICEF, every 11 minutes, a child between 10 and 19 end their own life, which is shocking every time I hear it. In this panel, we're going to discuss how suicidality is heavily interlinked with other factors in our lives that cut across the SDGs, including poverty, conflict, and the climate crisis, and how we as a global community, and this is the good news because I started with the bad news, but this is the good news, we know a lot about what is needed, what really helps a person in a moment of crisis. We do know interventions from ancient wisdom to community practice. We have innovations that are a lot more modern, a lot more newer to understand how we support those with severe mental illness and those in moments of acute distress. Today's panel is amazing. These are some of the people that have influenced my work for many years now and have fantastic experience and expertise. I'm going to hand over to them to start and to give a little bit of an introduction on themselves. So Raj, can I start off with you to give an intro?
Thank you so much, Natasha. Good day, everyone, and thanks for having me on the panel. My name is Raj. I'm the director of an organization called Mariwala Health Initiative, which is based in India. And what we do is mental health for marginalized communities by promoting community-based, psychosocial, rights-based, intersectional work. We also visibilize counter narratives, and some of the ways we do this are through grant making, advocacy, and capacity building. So just to give you an idea, we have about 60 partner organizations across 24 states in India, and we work with a range of stakeholders such as academics, activists, clinicians, service providers, and of course, persons from marginalized communities themselves.
Amazing. Thank you for that. Mark, you want to come in and give a quick intro?
Yes, I'm very happy to introduce myself. Thank you for organizing this and facilitating this. I'm really grateful. And my name is Mark van Ommeren. I'm the unit head in the mental health unit in WHO. I came to mental health, as many people come to mental health, with having my relative with mental health problems, in this case, my mother. So my interest in mental health has been as long as I remember. I professionally worked in mental health for 30 years, going through mainly through working with refugees in the emergency area. But I grew up in WHO over the years, and I'm the unit head covering a whole number of areas. Today, very much will focus, of course, on suicide prevention. And I'm delighted that this topic we're going to focus on this. And I think WHO is a well-known organization. It stands often in between the link between what the science says and giving advice to governments, and giving advice to civil society, and we give advice to funders. Thank you.
Thank you, Mark, and thank you for speaking so vulnerably also about your personal lived experience, which is something that's particular to the mental health space. So thank you for that. Chime, darling, you want to come in and introduce yourself?
Thank you very much, and it's great to be with a global panel here. I'm going to ride on the back of Mark and introduce myself in a way I was not thinking about, which is how I got conscripted into mental health. I've been diagnosed in the past with a mental health condition, so have members of my family. And so it's something that's very personal to me. And I think that it's important for us to have these conversations like Mark and share, because it gives other people the space to have that kind of conversation. And my personal experience is what led me to found something called Nigerian Mental Health. Um, it is the largest multidisciplinary network of mental health practitioners and organizations focused on advancing the mental health space in the country. We have over 50 plus organizations around the world, a majority of them in Nigeria, and we focus on primarily 4 areas of work. The first is policy, the second is research, the third is wellness programming, and the fourth is disability inclusion. And we've been working with multi-sectoral partners to do a lot of reforms, especially in the governance space, because we want to really increase the ecosystem. What we're really known for is 2-3 years ago, we got Nigeria's first mental health focus app passed, human rights focus passed since our independence. And now we're doubling down to see how we can advance the mental health space and make sure that all organizations really strive and thrive, because a lot of people are hurting and need the help and support that that we help try to fill those gaps in the country.
That's amazing. And again, thank you for sharing so vulnerable and explaining about the context of mental health in Nigeria. We're going to dive in a little bit deeper into that when we go through this panel, because I think Nigeria is an example of how you can really use suicide as a way of developing further mental health interventions. And you've got amazing experience with that. So we're going to kick off this panel, and I'm going to start with you, Raj. You have done so much in the space. You've been a mentor of mine and someone I admire for a long time. Your minority-based rights, your community-based approach to mental health is amazing. You set up the Alliance for Suicide Prevention to help stakeholders collaborate, which you mentioned at the beginning, particularly on preventing suicide at the individual and at the community level. So, a couple questions. How do you see this work integrating within the broader context of development in human rights, which you're very strong on? And what has the Alliance learned about how suicide prevention can most effectively be integrated into other areas of work?
Excellent question. Thanks, Natasha. Now, the reason that we started the Alliance for Suicide Prevention is that India accounts for about 17.5% of the world's population, but sees more than 25% of global suicide deaths. And, today at the core of suicide prevention in India, as is amongst many other low and middle income countries, there's the presumption that death by suicide is a problem that can be dealt with by providing individuals one-on-one help. So that's access to counselors, helplines, or by reducing access to means. And of course, these interventions are very important, but we cannot afford to miss the bigger picture, right? Whenever we see an article on suicide, it talks about suicide helplines, crisis lines, expert opinions, and this is an oversimplification just because it focuses on one individual, one factor usually, which is mental illness, and one point in a trajectory. And by that one point, I mean an acute crisis point. Right? So suicide helplines are designed for those who may be in acute distress or at risk of a suicide attempt. Now, this is absolutely critical, but if we take such a decontextualized approach, if we take such an expert-led approach to suicide, we actually let go of the fact that suicide is a complex problem and it can't be separated from social, cultural, economic, political, and historical contexts. And this is important because I said in the beginning, India accounts for a disproportionate number of suicide deaths. In LMICs, they account for 70% of global suicide deaths, but less than 50% of suicides in LMICs can be attributed to mental illness, such as depression, right? So how do you address some of the structural drivers of suicidal ideation in a place like India? And those can be poverty, discrimination, and exclusion. Now, of the suicide deaths recorded in India in 2022, about 1/3 were daily wage earners. I just read an article in the paper yesterday that said, in my state, 890 farmers killed themselves from just January to March, and that's 3 months, right? Similarly, so for young Indians, it's the leading cause of death for young Indians. And suicide is the biggest cause of death for young Indians. Now, if I take an individual approach, most research, even online, will tell you that it's due to exams and academic pressure, but that's only one small part of the puzzle. In fact, suicide in Indian youth, some of the 50% of the reasons were personal or social factors, family problems, forced marriage, falling in love with someone you're not allowed to fall in love with. And so how do you solve for that, right? How do you solve for, especially when it comes to suicide of young Indian women, socioeconomic vulnerability combined with control of their sexuality, limited mobility, lack of agency, threat of early marriage and pregnancy? I mean, these are some of the reasons why there is an emerging pattern of maternal suicide in India, right? And that is quite starkly different from where you look in the West, where people will talk about postpartum. In India, it's prenatal because it's socioeconomic concerns, domestic violence, pressure to have a male child. So how do you solve for this using just reducing access to means and an expert helpline? We have to solve for this by taking an intersectoral approach that foregrounds agency, the choice of young people, sexual reproductive health and rights, embed things in educational systems and in livelihoods, right? That's the only way to build a comprehensive response to address the structures that are causing suicide. Now, I'll give an example. I mean, this all sounds very easy for me to say on a call, right? But how would you build a comprehensive response? I spoke about the farmers that had died in my state just in these last 3 months. Now, the primary reasons for these deaths by suicide have been crop losses, mounting debt, lack of adequate minimum support prices, and absence of accessible credit. Now, what would a community-based intersectoral approach look like in this situation? Now, one such program that we fund, which is led by an organization called Shiver Foundation, they trained local community volunteers to create awareness about suicide, talk about common stressors that farmers experience. They're all trained to provide psychosocial first aid, and alongside that, details on government schemes, enabling access to cash support, enabling access to credit, as well as farming equipment. Now, apart from doing an in-person outreach from home to home, they run a psychosocial helpline for farmers, friend centers for people to drop into, and they have 700 local and community-based volunteers addressing this distress. But alongside addressing the distress, it's not enough. They also do links to market, debt relief, and even provide seeds, right? So such an approach, yes, provides help in points of acute crisis and is available where people already are, but it also leverages existing communities to create collective efforts to address this issue and to prevent the crises from happening in the first place. And now from a funding perspective, I'm just going to say that this reduces the need for costly expert-led interventions, which, by the way, are built into the linkages, but you'll see that it happens much less. So similarly, so for another partner who works with young persons, they work with marginalized youth who are first-generation learners, and they have physical centers, community outreach, they do street plays. This is a small territory, a union territory in India that has a very consistently high suicide rate. And of course, they have all the linkages, but these illustrate that local and contextual knowledge and empowerment are very key to addressing multiple factors that lead to suicide and its trajectories. Similarly, so, and we think about suicide just as acute crisis, but let's break it down into prevention, intervention, crisis response, and postvention. Because we know that people who experience the death of a loved one may also be susceptible to suicide. So this is why I say it is very much a development issue, because it is linked to these factors rather than the dominant narrative of living with a mental illness that could lead to suicidal ideations or death by suicide. And in such cases, it's very important to do community-led work that is contextual and based on lived experience. And of course, it is up to those of us with the access and the power, the funders, the researchers, the clinicians, to connect these dots in prevention work.
That was an amazing response, Raj, and there was so much there. I think you talked about the issue of suicidality in and of itself as a point of intervention and something that absolutely requires funding, but then also further is upstream or downstream suicide prevention, right? And the various other areas, all of which are really important. And then the issue of mental health as its own vertical versus horizontal, right? As a developmental issue, you talked about education and politics and economics. There was so much there. And above all, what I took away is kind of the lived experience and community-based approach to intervention and taking the local context. So I think that's a really good segue to move over to Mark, who works for WHO, and WHO has done an amazing amount of work to understand what we can all do to help prevent suicide. And also, to your point, Raj, about a comprehensive approach and a framework, WHO has provided a practical guide for action and best practice called Live Life, which is also fundable since we're talking to a group of funders. We're putting a link to the guide in the chat now. And within this guide, there are 4 interventions highlighted that are particularly effective for preventing suicide, and that would be priority areas for funders to address. So Mark, can you tell us maybe a little bit more about those 4 interventions? And then to Raj's point about, the contextual, maybe talk about the regional differences to how you implement this on the ground, particularly from seeing it from a WHO perspective, where you have a lot of country overview.
Thank you. I think what you do for suicide prevention probably also depends on the amount of resources you have. So if you have limited resources for a large population, you need to go for the most cost-effective interventions. So those are the ones that we have in our package. But I completely agree with Raj that much more is needed, and we need to look into determinants. It's extremely unsatisfying to just have quick solutions while the underlying causes continue and continue to generate suffering, including also suicide. The 4 interventions that the Live Life highlights is reducing access to means of suicide. That sounds really theoretical and for many people a little bit incredible. But in some countries, people used to cook on coal gas, and they use that for suicide. And then when in those countries they changed coal gas to natural gas, the rates of suicide just went down. And in other countries where people used to have painkillers in bottles, and they changed it to strips, and they changed it, and the suicides from that means would go down. And we have examples of many countries in the world where acutely hazardous pesticides were changed and the suicide rates completely go down. People think that's strange. Why would it immediately go down? Because would people switch to other means? But the reality is that many people only do one attempt. Of course, we all know about many people have many attempts, so it's not always, but most people only do one attempt. But they must survive that attempt. So that's why it's really important that there are no very dangerous means around, which in many countries is pesticides, in some countries is guns, be bridges, it could be all kinds of, there's more, but pesticides is 1 in 5 suicides in the world are from pesticides. And there is a lot to be done there with very, very little money. A lot of laws can be changed in many countries to ban pesticides. The second part of the live life is not reducing access to means, but it's working with the media. The reality is that suicide is a tragedy, but it's also very interesting to people. So the media likes to write about it, particularly celebrity suicides. And then it becomes easily glamorized, and you have copycat suicides. So working with media and journalists to and newspapers to do responsible reporting, not sharing the means, not glamorizing, but giving information about suffering and where to get help is the way forward. Very, very good intervention. The third intervention is basically mental health promotion with young people. So it's teaching them social emotional skills, addressing bullying, doing the good work with adolescents, which I imagine has already been covered today in these sessions. And the last one is the early identification, assessment, and care. Those are the four. And what we know is also that when different suicide interventions are done together, it's synergic. I'm not very good. English is not my first language. Synergistic, synergic. And it's really good to have them together and so having a funded national plan to implement suicide prevention is really important. Having a plan is nice, but a funded plan should have a budget, and the budget should be funded, and then we can go. This is, of course, obviously we work with national governments often, or if it's a large country, maybe with their provinces or states, but that's the big population approach. And I very much agree with Raj that it's really important to think that it's just not just counseling or just making mental health services available, which we very much want to be available, but that's not how the suicide rates are going to change. And the amount of investment in suicide prevention is so small. It's so small. It's like from research, 0.5% of all the research money goes only into suicide prevention per se. So it's very tiny, but it's the only sustainable development goal. And it's actually the one thing we can make an easy change. In terms of regional differences, well, one of the biggest regional differences is the means of suicide. That's for sure. That is, different means are used in different places, but there are definitely different determinants in different countries. Some countries violence will be a bigger role. There's also a lot of learning. There is some contagion in suicide. That's why, of course, the media training is so important. So it could also be that in a certain area, people just learn more about solving their emotional problems, trying to solve their emotional problems with suicide and copying it from each other. So there is regional differences. But the main strategies, I think, are largely similar. And as we like to say, is we know enough about what works to take action. And I hope we will do more. In terms of live life is being implemented in a number of countries. We just started in Cambodia, Uruguay, Suriname, Bangladesh. So there is a number of countries where we're moving with live life, and pesticide suicides. This work all around the world. So this is not just a theoretical work. This is work in progress. Thank you.
Yeah, it's amazing. And I totally agree with you. We do know a lot more and we do know what works. But I wanted to say something. You talked about national plan is nice, but we need a budget. And I love that to be that stringent. I was going to be optimistic and sort of say, I think suicide is a really important entry point for funding to have change, but the national mental health strategy is really important. That can be a springboard for helping countries go beyond that. But to your point, without the funding, it's really difficult. And I loved what you were talking about on a country level. I think what the work you're doing is really important to hold countries to account, which is important, and to monitor them and try to see how we address this as an SDG problem. So honing down from the global level and to the country level, which you mentioned at the end, you mentioned a couple of countries and reflecting on the regional differences. I'm going to turn over to Chime. Your work is something that is particularly close to my heart, which is decriminalization of suicide. It is actually, I think, some of the first parts of mental health that I started funding like a long time ago. And I think it's not that well known that it is still legal to die by suicide in 25 countries around the world, affecting nearly 1 billion people. But progress is being made with legislation criminalizing suicide that has been successfully repealed in recent years. Guyana, Pakistan, Ghana, Malaysia, we can go on. I don't mean to point fingers, but like slightly. My bad. So to your question, can you tell us more about the realities about a campaign to decriminalize suicide and what it takes to be successful? Because that's hard work. And then again, how does this work look differently in different countries?
Thank you so much for the question. And it is shocking that suicide is still criminalized in some countries. As you mentioned, the range vacillates between 20 and 25 based on the resources. But we know that individuals who are in this acute mental health crises, they don't need jail, they need support. And that's what we're doing to work in Nigeria. Nigeria, unfortunately, is one of those 20 countries or so that still have suicide criminalized. And really, our work to decriminalize attempted suicide started back in terms of our multi-coalition efforts to pass the Mental Health Act. And Nigeria had something called the Lunacy Act, which was a vestige of British colonialism. One of the things that is really important to understand is that the countries you mentioned, like Guyana, Malaysia, these are all products of British colonialism. And that's why that we had these really arcane mental health policies. Right a year after Nigeria was independent, Britain actually passed their suicide policy, but we were independent, and the legacy continued, unfortunately. And so it started with the Mental Health Act that we got passed in the December 2022. And the reason I say it started with the Mental Health Act is we are very conscious as a coalition that we had to link these demands, that we had to link the demand to pass a new Mental Health Act that guaranteed rights, that guaranteed individuals can be involved in their treatment, that they couldn't be pained and things like that, to a conversation around decriminalizing attempted suicide. There was an important information from the World Health Organization that found that if we wanted to execute and consolidate the gains of a mental health act for human rights, we need to make sure that people had help-seeking behavior. And so there's no way we can have a mental health act and we have other laws that penalize individuals from getting the help and support they need. So very early on, before we had a sustained campaign called Suicide Not Crime NG, we linked those demands together in our press releases and our conferences. And this is what's important about working with a coalition. This wasn't an originally part of our press release. This was something that other actors were debating, and when we were discussing how to proceed, this was one of the things granted, and it was one of the things that made it in our first initial demands to the presidency. The second thing is that we had to build on past efforts. What was interesting in terms of the Buhari administration in Nigeria is that earlier, before a Mental Health Act passed, they actually had passed different legislation focused on disability. So they passed a Discrimination Against Persons with Disabilities Prohibition Act in 2018. They also inaugurated a National Commission on Persons with Disabilities. And we found out that the president, actually, from his wife, had been diagnosed with PTSD. And so we used those conversations, that lived experience, those past gains, to talk about how if you want to have a legacy, and he was going to, and if you have a legacy that defined your presidency, something you should really double down on was disability. So trying to link that into the context of what the president's past works and reforms are. The second was creative advocacy. So my other panelists have mentioned things like the media. We had demonstrations, and we did something that we thought was important. Well, we also had advocacy in the context of wellness programming with the Federal Ministry of Health, with actors like um, UN and others. We thought it was important to it's hard to protest. It's hard to advocate. We thought it was important to encourage individuals by doing things like yoga and art and dancing to show that protest didn't just have to be taking to the streets, but also encouraging community, encouraging collective solidarity. And those things really helped us. And in the back of these sessions, we would actually have our petitions that people can write. We would share more information, and it gave us a different type of environment and context in order to distribute our information and our goals. The next thing I would say is that it's important to partner with key actors. So when we got the Mental Health Act passed, you can't just end there. We wanted to meet really, there was a new administration that won the presidency. I just mentioned that the last president was about to go out, a new administration, and we wanted the new administration and the new government actors to really prioritize mental health. So we had a conference, Nigerian Mental Health and other actors within our network. We held it with the National Commission on Persons with Disabilities that I mentioned before, and the National Human Rights Commission. And there we outlined a 10-point goal in order to change and how to prioritize mental health. And encourage things like, making sure they incorporate diverse actors, incorporate persons with disabilities, nothing about us without us, increase funding that has been mentioned before, and also change how the nature of funding. It's not just increasing funding, but it's also making sure that the limited funding that goes to mental health goes to things like not just biomedical conditions, but also psychosocial support. A lot of people don't know that. A lot of people don't talk about the amount of budgets when it comes to mental health relative to national governments, but they don't know that that limited amount, 99% of it usually goes to biomedical support versus psychosocial support, which is really, really key. And so those were some of the demands and linking these to key partners to help legitimize our claims. Then once we got this, and once we started pushing on the Mental Health Act, we really focused on suicide decriminalization. We got our hashtag suicide, not crime, NG. That was something agreed on by stakeholders. We made sure that we incorporated a multi-coalition stakeholders, which was really important. One of the problems we had in the past is that, and this is not a critique or anything like that, it's just that the advocacy had been dominated by one organization and one group, and it was the psychiatrists in Nigeria. So great organization pushing, but we know that mental health impacts various stakeholders: psychologists, human rights defenders, social workers, psychiatric nurses. And so we made sure that we were the first one to get them all on board in terms of coalition. So all of Nigeria's 4 leading professional organizations, we got them to sign on to the movement. We ultimately grew our coalition from an initial of 10 to at the end we have 40 plus organizations sign on to the call to decriminalize attempted suicide. We made sure that we mainstream suicide decriminalization in other aspects of government. So one of the things we also got passed was a national suicide prevention policy, working with organizations like the World Health Organization. We're one in less than 10 countries in Africa that have a standalone suicide prevention policy, which calls for decriminalization of attempted suicide. So it wasn't just protesters or activists that are working on this. It was also individuals. It was also a official government policy that was ultimately adopted by the National Health Council. So it helped with our demands. We make sure we research the issue. So we had a policy brief, and that policy brief, we used celebrity stakeholders like MI, who's on social media, he has 1.3 million followers. He's somebody very passionate. We also launched our policy brief with the Federal Ministry of Health and other actors. And that's where we uncovered things that were shocking to us. Really understood the colonial nature of some of these anti-suicide laws. And so that what we were doing was a stance, a resistance to this past discrimination. And then we've uncovered other things, such as increases in suicide particularly amongst women, happen in countries where suicide is criminalized. There's the first study that's done to systematically review this issue was done by the BMJ Public Health in 2022. And that's what it found, that there was higher rates of suicide in countries where criminal punishment for the act. And so connecting some of these gender challenges, for instance, when it comes that a lot of people don't know, so we can get a broader swath of individuals that were engaged in these issues. We have our change.org petition, ultimately has thousands of signatures. And we try to present a very clear vision. This is also very different than what has been done in the past. A lot of efforts have failed because we have just said we want suicide decriminalized, or we have just said we want Mental Health Act. What we did here is, instead of telling government this is what we want, we presented them how it should look. So we worked for months with a coalition called Nigeria's National Suicide Prevention Coalition, and we actually drafted a bill. And this was very distinct than what other countries, like you mentioned Malaysia or Ghana, at the time we were also looking at Kenya, they had just decriminalized. But we thought that wasn't enough. We didn't want to just repeal our penal code and our criminal code. What we wanted to do have a framework, so we had government buy-in, because you have to execute a law. We want to make sure that people got the support they need when they were in moments of crisis, that there was things like a crisis hotline established, and that would have more stakeholders galvanized, where it wasn't just repealing something negative, but presenting something that was a bit more holistic. So we presented a clear vision. That draft bill we sent to the Attorney General's office to be reviewed. We sent to the Federal Ministry of Health, and we held a conference last year. And that conference was with organizations like Lifeline, which is also leading ACEDO Foundation, Nigerian Mental Health. And we did two important things at that conference. One, we presented the draft National Suicide Prevention Bill and invited government stakeholders, but also we held something called an immersive conference, because mental health is something that we want to feel, and people to be vulnerable and empathetic, and we can use emerging technologies to do it. So we use virtual reality to actually demonstrate to individuals how it was to feel and experience something like a mental health condition. And so they can be empathetic and have new form of advocacy where they can connect to the issue and destigmatize it, because it's very stigmatized in the country. And so based on that conference, we had a senator actually attend the conference with a representative. And I'm happy to say that conference happened in November. Earlier this year, the first quarter of this year, based on our suicide prevention bill, that senator who attended introduced our legislation for first reading. And now we are working with that legislator as we speak. Tomorrow, we're actually having we're launching something, Nigeria's first national directory on mental health and rehabilitation services. That senator is going to speak as our keynote speaker, and we're continuing to work with that senator to engage with the National Assembly, engage with the Attorney General's office, engage with the Federal Ministry of Health, so we can push this important legislation. So it's important to get the stakeholders, a diverse group of stakeholders involved, understand what the issue with things like policy brief, but also engage in creative advocacy and present a clear vision. And the one other thing I was going to say about clear vision is just to amend the point about funding. Funding is very key for national legislation, and we need national legislation, but we need clear metrics for these things. We need a clear roadmap for these things. And so it's important not to just fund things abstractly, but to fund a clear vision with clear metrics so we understand what the goals are. A lot of policies and strategies we have in the past have failed because there's not a clear roadmap and monitoring and evaluation. And that's something that we're working on as a community right now, to make sure there's clear monitoring and evaluation for all the national strategies and the roadmap for a Mental Health Act, to make sure it's executed and it really benefits the individuals that it's supposed to impact.
Thank you, Chime. So that was a lot of information. So I just want to, just because the audience is a funder audience, so I don't want people to get overwhelmed of like, there is so much to do. I want to break this down a little bit into some of the points that you were talking about. And I think one of the key things that you, Raj and also Mark were talking about, coalition, collaboration, right? One person, one funder cannot do it all. So I think there were various areas that you've all highlighted that can be fundable, but also just I know what it's like to be a funder. Know that you are part of a community that is moving in this direction, right? And there are resources available, and all these organizations have some fantastic information on their website. I'm a big fan of advocacy and policy funding, so I think that's a great area to invest. You talked about virtual technology, talked about storytelling and media. Mark, you were talking about copycat. I think that is a really, really important point. It's not just about the financial capital, right? Storytelling, narrative culture is really, really important. So I think we need to be careful about how we talk about this, and it always has to come from a rights-based perspective. So not just the funding, but where we're going to. Raj, I'm going to quickly turn over to you before I go into like an open discussion. I know that some of the things that Chime was mentioning resonates with you. So I don't know if you want to add anything before I ask a few other questions.
I mean, I think um, the looking at it also through the lens of colonization and the laws that a lot of these countries inherited is important. And in the same vein, if we don't, I think, enlarge our vision of what suicide prevention is, we would be repeating some of the colonialism. And here's some history behind it. The idea of using prevention or preventing access to means came about because they were preventing African slaves on ships from killing themselves before they went into a life of slavery. So that's the history of that. So if we use or if we focus only on individual-led methodologies, we will be embedding our suicide prevention work with colonialism itself. And because there are so many factors that contribute and so many structures that contribute, it's much better to take a wider ranging approach to suicide prevention, especially in LMICs where we know the bulk of suicide deaths do occur.
I love that. And I think, again, from a funder perspective, which is often where my head is at, even if you're investing, I mean, Chima, you talked about gender. Um, I often talk about climate because I mean climate is overwhelming. You can have a mental health angle to that funding, right? So you talked about not just increasing funding, but the nature and characteristics of funding. So on that note of funding, I'm just going to open this up in the last like 5 minutes that we have before I wrap up. What do you think are really good entry points for funders that want to get started in this area? Because that's the community we're talking to. Which organizations or resources would you highlight for those that who want to know more, and where should we start? I'm opening it up to you guys.
I don't know to what extent there are national associations for suicide prevention, but there is the International Association, which likely would have links to national associations. But I must say, I'm not cognizant of what it looks like at the national level. But if there's one at the national level, I would look into it and then see if it's who's there, if it makes sense. Depends on the capacity and all that. But I think that would be certainly a place to go. I would definitely look for local expertise and I think it's very important to look for places where people do more than just one single intervention. It's a whole bunch of things that come together that are likely are going to budge the suicide rates.
I would thank you for that. I would offer a couple of things that I think are important. One, I think advocacy work is important as you mentioned. We're I hate to toot our own home, but Nigerian mental health is a good place if people want to put some money behind. Support for media is not easy, stakeholder engagement is not easy. Hosting conferences is not easy, and trying to be creative, getting the technology and seeing if we can procure the technology. I think a lot of funders don't understand. Don't understand that human capacity is something that, these things don't just emanate from anywhere, right? There's people who make this happen. And so I would really support the work. And we are doing this on string branch. And I just imagine if we got a little bit of support, we could really do something that for a country that this, a country that has the biggest population on the continent of over 200 million. So I think that's a good place to start. Another thing I'm going to say is around research. So Raj said something very important about the framing around suicide prevention strategies and policies, and I think that's something that's informed by their experience in India, and we have experienced something similar on the continent when we were thinking about where to work in the context of mental health act. A lot of what we borrowed from was in Kenya, but there's India probably a better illustration in terms of a shared colonial history, huge population. So we should be looking at other comparative examples of what we can learn. And so we are doing work where we're reviewing global suicide prevention policies, also trying to reimagine what that could look like. Ones that perhaps don't particularly highlight or just frame suicide prevention, but just mental health crisis like our panel is. What does a country like Nigeria have to offer other countries that are in the inaugural sessions of this? Can we learn from those experiences, and can we do that comparative global post? I haven't seen that type of research. That's research we're working right now with Northwestern Center for Racial and Disability Justice, and that's something that we would love individuals to get involved in, so we can take the lessons that we've had with that as a mainstream revolution in the country and really export that for other countries to learn from our lessons on the ground.
I love that. And I'm conscious of timing, so I'm going to start wrapping up. But I think what you said about South to South learning, I think that's really, really, really important. I'm guilty of this myself. I mean, I'm half Colombian, but I sit in the North and we have research papers. You also talked about mental health being in the psychiatric realm. That was certainly how it was for me 15 years ago. And it's great. We had a huge amount of research, but I would look at them and at the end, I'd be like, what action could I, as a funder, take? I didn't know. And we are widening that up, and the knowledge is there. And I love that this is slowly happening. You also talked about funding events. I love that. And particularly funding activists from the South and people with lived experience to be at the table. To your point, I think that's a huge resource that we do not explore enough. So there is so much that we can do here as a funder community. Again, I'm just going to highlight the biggest takeaway that I took from this panel today: intervention, activation, support, and funding can happen at so many levels. Vertically, community, country level, individual, also horizontally across the different SDGs. I want to say how grateful I am to the speakers today, not only for showing up here today, but for the work you do. This is unsexy, like from a funder's perspective, hard work where the returns on the funding is not easily measured. You mentioned metrics, but it's so necessary. My father died by suicide. Last week was his suicide anniversary, and so I know what that's like and know what that's left with. So I am very, very grateful to you, and I'm sure that so much of our audience here. I'm grateful to NEID for putting this panel together. You guys are amazing. Links have been posted in the chat, and so will the speakers' availability. So if you have any other questions, then please reach out. Thank you so much, and I look forward to the next one.